Can we go live?
Take a countdown, go live.
Good evening, friends, ladies and gentlemen. I would like to welcome you all this evening for this national webinar on heart failure with preserved ejection fraction. This has emerged as a global epidemic, accounting for anywhere from 30 to 40% of heart failure population. It used to be called an orphan disease because we didn't know what it was, diastolic dysfunction, and we were just labeling it and moving on. But there are a lot of interesting developments thanks to our basic scientists who have slowly unraveling the pathophysiology and the molecular mechanisms of coronary microvascular dysfunction, inflammation, and fibrosis. And this has become more a systemic vascular disease and inflammatory disease. And this is a kind of a selfish venture to learn more about this disease. I have kind of put together an impressive array of people who would walk us through some of the concepts regarding diagnosis, imaging modalities, management, and what is in the pipeline regarding of heart failure and preserved ejection fraction. We have a stellar faculty, and I'm really thankful for all of them for joining this. Without much ado, we would like to call upon the first speaker, who's the past president of Heart Failure Association of India, and he has been representing in the Indian subcontinent all over Europe and has been pioneering in several of the global heart failure trials. Dr. Vijay Chopra, he'll be talking to us about heart failure with preserved ejection fraction. Can you start?
Hello, everybody. I'd like to thank Dr. Narasimhan for inviting me to this discussion on HPpEF. In the next few minutes, I'm going to discuss the changing paradigm of heart failure with preserved ejection fraction. Is the classification of heart failure based on ejection fraction still valid?
You have to unmute yourself.
We know that there are three categories. Less than 40% is
so
reduced.
can we go to the first
Over
slide,
50% is
Thank you, Dr. Narasimhan, for setting up the
then
context.
in between, it used to be called
So heart failure with
mid-range,
preserved
but now
ejection
it is called
fraction,
mildly
as he has
reduced
mentioned,
ejection fraction.
is a
However,
condition
we
which
know
is
that the boundaries
being
are
recognized
blurred
more and more.
because many
I still
times
feel that
the ejection
HREF
fraction
is the
changes
dominant
depending
condition in our
upon
country
various
thanks to
conditions.
several factors.
For example, heart
But
rate,
it is also
loading
true that we are
conditions,
missing a
and
lot
so
of
on.
HPpEF.
In addition, there's a
Now, when we
measurement
talk about
error
heart failure,
due to inter-observer
questions have been raised
intra-observer
whether
variability.
classification of heart failure based
And many
on
times
HPpEF
when
is really
we
valid
give
or not.
ejection fraction in the report,
Because
it is
we
mentioned
know
as 35
that,
to 40 or 55
there's
to
a range in between,
60%.
which used to be
And
called
therefore the boundaries can
mid-range,
be
now it is
blurred
called
at
mildly
times.
reduced. But we know that
Also,
there are several
we know
factors which are responsible
that
for this.
the
Loading conditions,
LVF phenotypes can change over a few months or
heart rate, and
years.
so on and so forth.
For example, in this study,
and then
they
people
found
move from one
that
ejection fraction
60
to
to
the
90%
other. And also,
of HPpEF patients
is
remained in
39%
HPpEF,
really
but
different
rest
than
of them
41,
could move down
or
to mildly
is
reduced
49% really
ejection
different from
fraction.
51? So you have to see
Similarly,
the totality of the picture.
mid-range
And it has
EF
been seen in
patients
this particular
nearly
study that dominantly heart failure with preserved ejection fraction stays in the category, in the same category, but 10 to 20% patients move down into HFrEF or mildly reduced. And same thing happens with mildly reduced EF and heart failure with ejection fraction also. So therefore, it is a moving target, and it all depends upon the treatment, the control of various factors, natural history. So we really have to see the totality of picture before we start classifying, and by the implications start treating them accordingly. Next, please. Next, please. Can some Dr. Narasimhan, the slides are not moving. Shall I? What happened? The slides are not moving.
Your slides and audio are playing. Can you? It's not coming.
Oh,
up.
achha. So I keep quiet.
Yes,
but I
yes.
couldn't hear it.
No, it's playing, sir. It's
Oh,
playing.
okay. Sorry. Sorry.
But even I cannot hear it.
Even I can't hear.
This.
Narasimhan, I don't think they're playing.
opportunity to introduce the chairpersons for the first session, Dr. Rajiv Menon, who's heading the cardiology here, and Dr. Chandramukhi and Dr. Alagason, who are pioneers in the era of echocardiography and imaging. Yeah, go ahead, please.
Hello, everybody. I'd like to thank Dr. Narsimhan for inviting me to this discussion on HPpEF. In the next few minutes, I'm going to discuss the changing paradigm of heart failure with preserved ejection fraction. Is the classification of heart failure based on ejection fraction still valid? We know that there are three categories. Less than 40% is reduced, over 50% is preserved ejection fraction, and in between it used to be called mid-range, but now it is called mildly reduced ejection fraction. However, we know that the boundaries are blurred because many times the ejection fraction changes depending upon various conditions, for example, heart rate, loading conditions, and so on. In addition, there's a measurement error due to inter-observer and intra-observer variability. And many times when they give ejection fraction in the report, it is mentioned as 35 to 40 or 55 to 60%. And therefore, the boundaries can be blurred at times. Also, we know that the LVF phenotypes can change over a few months or years. For example, in this study, they found that 60 to 90% of HPpEF patients remained in HPpEF, but rest of them could move down to mildly reduced or reduced ejection fraction. Similarly, mid-range EF patients, nearly 30 to 40% remained in that same range, and rest of them could move both up and down. In reduced ejection fraction, many of them remained in the same group, but as a result of therapy or certain other conditions, they kind of changed over into mildly reduced or even preserved ejection fraction, especially if certain conditions were treated. So what is the evolution of pathophysiology? It has evolved. Old concept was diastolic heart failure, as it used to be referred those days, develops into systolic heart failure over time. For example, hypertension first leads on to diastolic heart failure and then systolic heart failure. We don't use those terminologies today. The prevailing concept is that HPpEF and HFrEF have distant pathophysiologies, whereas adverse conditions like ischemia, infection, and toxicity result in direct cardiomyocyte injury, resulting in heart failure with reduced ejection fraction. HPpEF is a result of several comorbidities which lead on to systemic inflammation, coronary microvascular, and endothelial dysfunctions, leading on to HPpEF. The emerging concept is that HPpEF encompasses a range of phenotypes that can overlap. So it's not necessary that the phenotypes remain the same, they can overlap. As I mentioned, in HPpEF, there is microvascular dysfunction, inflammation. The preponderance in this group is non-cardiovascular death because they are elderly people, and there's reduced response to standard heart failure therapies because of their wide heterogeneity. On the other hand, in heart failure with reduced ejection fraction, there's a cardiomyocyte injury. This group of patients largely have cardiovascular deaths, and the response to heart failure therapies is much more standardized and it is more predictable. So there are numerous phenotypes which are encountered in HPpEF. HPpEF is the most common form of heart failure in elderly population. Among elderly women, HPpEF comprises almost 90% of incident heart failure cases. The prevalence of coronary artery disease, HPpEF, ranges from 35 to 53%, and these patients have a worse prognosis than those who do not have coronary artery disease. HPpEF is a common cause of pulmonary hypertension, occurs in 30 to 85% of HPpEF patients in different studies. A new understanding of phenotypic heterogeneity of HPpEF includes a proposal of a pro-inflammatory phenotypes driven by comorbidities, and this is especially important in conditions such as obesity and type 2 diabetes. And approximately 80% of total HPpEF population today are living with overweight and obesity, which is being increasingly recognized as extremely common. What are the future applications of phenotyping of HPpEF? Optimization of phenomapping studies are required. For that, we need to use longitudinal data to study stages of disease, and application of underutilized data. For example, invasive hemodynamics, exercise data, coronary pathology, skeletal muscle physiology needs to be studied. We need to have expansion across wider spectrum of EF in heart failure and utilize prospective trial structures. In terms of mechanic and physiological translation, we need to validate proposed phenotypes through connection to mechanisms of disease. We need to develop focus animal models to study specific phenotypes and investigate novel mechanisms of HPpEF via basic and translational study of new patterns. Among clinical trial investigations, we need investigation of hemodynamically characterized phenotypes of HPpEF, evaluation of targeted therapies of obesity and cardiometabolic phenotypes of HPpEF, although much data has emerged, but still more work needs to be done. And we need to have a much stronger evidence base for this group of patients. The first study of phenotypes of HPpEF was soon after TopCat trial. We know that TopCat trial investigated the role of spironolactone in patients of HPpEF. The trial was negative, but then they had stored and frozen some samples, and they were analyzed subsequently, and they measured parameters which are not part of the initial trial. This was published in 2020, and it dealt with detailed phenotypes, prognosis, and response to spironolactone. And the information was very interesting. The first phenotype mentioned in blue referred to in these patients had normal LV geometry, low arterial stiffness, low natriuretic peptides. There were markers of COPD which were present. Probably many of them were not in HPpEF, and there was a low event rate. This group mainly came out of Russia and Georgia, which was responsible for wide variation in results. The second phenotype consisted of concentric remodeling, very stiff arteries, enlargement and atrial fibrillation, high natriuretic peptides, innate immune activation, and there was a high risk of primary endpoints. The third phenotype referred to patients with obesity and diabetes. These people had evidence of inflammation characterized by raised TNF alpha, abnormal metabolism, renal and liver dysfunctions, high renin, and the higher risk of primary endpoint. This was the group which responded best to spironolactone. So even within that, you can tease out the phenotype which is going to respond to spironolactone. Not surprisingly, on the right-hand side, you see primary endpoint. The mortality, understandably, was the least in first kind of a phenotype, and increasingly more in second and third kind of a phenotype. So why is obesity so important with so much of a emphasis being placed on it? Obesity results in glucose intolerance, hyperleptinemia, sympathetic nervous system and RAS activation, inflammatory activation, and myocardial steatosis, which leads on to increase in blood volume and cardiac output, resulting in increased LV mass and concentric hypertrophy and increased LV filling pressure. Also, because of increased epicardial adipose tissue, there is restriction to RV filling, increased pericardial restraint, and therefore increased ventricular interdependence, leading on to reduced LV filling, and again LV filling pressure is increased. There is increase in exercise right atrial pressure and pulmonary capillary wedge pressure and reduced pulmonary vasodilation, and together all these get together to cause symptoms of heart failure and reduced exercise capacity. So for practical purposes, this is the score which is useful for a physician called HPpEF score. H2 refers to heavy. H2 refers to two parameters. If body mass index is more than 30, they get 2 points. More than 2 antihypertensive drugs, 1 point. Atrial fibrillation gets 3 points. Pulmonary hypertension, age over 60, and filling pressure characterized by E prime over 9 gets 1 point each. More than 6 points are highly diagnostic of HPpEF. 2 years ago, we had published this paper. I was fortunate to be a part of this paper. This dealt with patient phenotype profiling in heart failure, preserved ejection fraction, to guide therapeutic decision making. And this was a scientific statement from behalf of HFA, EHRA, and ESH. You can see the number of different phenotypes which were identified in this particular paper. So elderly age, coronary artery disease, female sex, chronotropic incompetence was present in a large number of people. Obesity was at that time was in 30 to 40%, but of course that has significantly increased. Iron deficiency, sleep apnea, type 2 diabetes, chronic kidney disease, functional tricuspid regurgitation, tachycardia, pulmonary hypertension, atrial fibrillation, COPD, cachexia. So these are all contributing factors to phenotype, to HPpEF. And many times there is an overlap, that is more than one can be present in a person. Elderly person could have diabetes, hypertension and coronary disease, and similarly different combinations are possible. So that is the reason why finding a unified therapy for HPpEF has been extremely difficult. One or two agents have worked, as we can see, but largely it still needs a lot more work to be done if we are to treat these patients. So what are the treatments across the range of LVEF available today? If a person has got fluid overload, loop diuretics are required. SGLT2 inhibitors have been established to work across the spectrum of ejection fraction. They reduce hospitalization and death, reduce renal endpoints, and they reduce cardiovascular events and cardiovascular death. MRAs were always useful in mildly reduce and reduce ejection fraction. After fine arts, probably their role in HPpEF will also get solidified. Beta blockers and ARNI work mainly up to an ejection fraction of something like 50 to 55%. So, to summarize, SGLT2 inhibitors, definitely. Diuretics, if congestion is present. MRAs, data is emerging. And then, depending upon various comorbidities, if there's iron deficiency, get ferric carboxy maltose. Ischemic heart disease will get either pharmacotherapy or revascularization. Atrial fibrillation, pharmacotherapy or pulmonary vein isolation. In diabetes, type 2 diabetes, GLP-1 receptor agonist role is being established. Finerenone if CKD is present. For arterial hypertension, various therapies have been standardized. In obesity, there's a rapidly emerging role of semaglutide and tirzepatide with so many papers being published. And in COPD, beta-1 selective blockers have a role. So concluding, therefore, the prevalence of HPpEF is steadily increasing due to various factors. Recognition in our country and in many others is still inadequate, largely because normal EF is still equated with no heart failure by many physicians. Normal or mildly raised natriuretic peptides do not rule out HPpEF, especially in obese. Identification of structural heart disease and better application of echo parameters will help. Novel mechanisms of HPpEF via basic and translational study of new patterns need to be elucidated. Today, SGLT2 inhibitors and MRAs are indicated in all HPpEF patients except in infiltrative disorders where the role is not clear. But strategies for targeted detection, trials, and therapies still need to be developed. With that, I would like to thank you for a very patient listening.
Thank you so much. I'll open this for the chairpersons to take over. Dr. Alagason, Dr. Rajiv, and Dr. Chandramukhi. Are there any questions in chat box?
Thank you so much, Dr. Chopra sir. I think that was an elegant overview of where we are as far as HPpEF is concerned. Just a few comments would be one of the things which is often missed. What happens is when a clinician sees a patient with HPpEF, he is more worried about how to treat and the fear that he may not actually reach the target and the patient will keep coming back. In that anxiety, they tend to miss the reason why the patient has gone into HPpEF. As you have mentioned, the different phenotypes which can produce HPpEF. Often unrecognized reason for HPpEF is the high output heart failure. And the advantage of identifying that high output heart failure is most of them are totally treatable. And we have had a lot of patients once we correct the underlying etiology, be it AV fistula or any of the other underlying conditions. The patient can almost go off drugs and lead a normal life. I think if you can just share your experience about these high output heart failures presenting as HPpEF.
Rajiv, I think you have mentioned everything that needs to be said. Now, regarding the first point, reaching targets,
now with two drugs being more or less recognized, that is SGLT2 inhibitors and finerenone in these patients, I think some kind of a standardized treatment will come up. Then on top of that is ARNI, which has been shown in the combined analysis by Solomon and McMurray that up to 55% or so it works. Of course, we also know that as the ejection fraction reduces, the effectiveness of all these drugs, beta blockers and ASR Barney, keeps on increasing. High output heart failure, I think you mentioned everything. And as you said, it's a highly treatable condition and therefore one should look for it. But generally, the signs are obvious, tachycardia, bounding pulse, and so on and so forth. So something similar to what you see in aortic regurgitation, etc. Something like that, if there is, then one has to look for these.
Thank you.
Sometimes hyperthyroidism and Paget disease are often missed. Sometimes
Yes.
that's two conditions which we don't recognize at all. I have a question with heart failure, preserved ejection fraction. How many percent of the patients, in spite of the treatment, go on to develop reduced ejection fraction? And the other question is, in heart failure with preserved ejection fraction, if you treat the coronary artery disease, is it likely to make a lot of difference in the patient's symptoms? Apart from the angina, the dyspnea ability improve.
So taking your second question first, if ischemia is playing a dominant part, then of course relieving ischemia is going to help in these patients, and this we have seen a number of times. I still remember a patient of CKD who used to be in and out of the hospital, maybe several times in the 2 or 3 years that we followed. When we did an angiogram, there was one single tight lesion that was opened up, and then that was it. Then subsequently everything settled down. Regarding how many patients move up and down, in HPpEF, nearly 60% of the patients remain in the same category, 60 to 70%. That is what the data showed, which I showed in my slide. But there would be about 30% of patients. Some of them move into mildly reduced and some move into HFrEF. HFrEF patients dominantly stay in that same category with a smaller number moving up and down, depending upon whether you've given them a CRTD, treated their treatable conditions, or even with good standardized pharmacotherapy.
One of the other things which I have seen is patients with type 1 diastolic dysfunction with very mild symptoms with left ventricular hypertrophy, small ventricles and all that. When they develop atrial fibrillations, immediately they develop pulmonary edema, they go in for cardiac failure and all that. And in those patients, is it wiser to treat the atrial fibrillation energetically or try to convert it with the ablation procedures?
I think that Dr. Narasimhan will be better qualified to answer, but if atrial fibrillation has been the triggering cause, then it is to be treated. If the total condition is such that it can be ablated today, that will be the first choice. But there are several conditions, for example, infiltrative cardiomyopathies and so on and so forth, which Narasimhan will better say whether they really work in those categories or not. But if nothing else, at least the heart rate control is required. Atrial kick is very important in these patients, as you very rightly mentioned. And therefore, once that is lost, they easily go into heart failure.
Thank you very much,
Sir, many patients, can I have a question? Many patients with obstructive sleep apnea, they have unrecognized HF.
Yes.
So
that is being recognized very significantly now. Telltale signs of obstructive sleep apnea is present in majority of the patients. If that is so, then a sleep study should be done, and then that should be appropriately treated. I think Dr. Narasimhan is trying to say something.
No, nothing, because we are running short of time.
Yes, okay.
We'll have more time for discussion, and the panelists, we have an expert panel who will go through some of these unanswered questions. In the interest of time, I would request Dr. Shantanu Sengupta, who's been leading several workshops and going around the country educating people about echo in heart failure. He'll be talking to us about imaging insights in HPpEF.
Dr. Narasimhan, with your permission, I'll leave. I have to go somewhere.
Yes. Thank you so much for joining.
Thank you. Have a good meeting.
Thank you, sir.
Thank you so much for this invite. Very important discussion on HPpEF. So my task today is to tell something about the imaging concepts. So I will give you some imaging insights on on how to diagnose and how to manage patients of heart failure with preserved ejection fraction. And I'm going to simplify and try to tell something about the echo measurements which are utmost needed. I don't have any disclosures. So we need to understand HFpEF carefully because it's a heterogeneous disorder. Unfortunately, we have seen that these patients who come, they are very different amongst each other. So one size doesn't fit all. And there are a lot of gray zones in the diagnosis of diastolic dysfunction in HFpEF, and it can be challenging sometimes. But we do need an earlier diagnosis because if we get them early, the prognosis is better in this subgroup of patients. Now, there are unique structural and functional and ultrastructural changes which are very different pertaining to HFpEF and HFrEF. And as you can see, regarding the left side, in HFpEF, the volumes, the LV volumes are more or less okay, while in HFrEF they are enlarged. The thickness is higher in most of the patients of HFpEF. The remodeling is concentric in HFpEF, while it can be eccentric in HFrEF. The ejection fraction, the stroke work are preserved, which are reduced in HFrEF. Regarding the ultrastructural changes, the myocyte diameter is higher in HFpEF, while the length is higher in HFrEF. And the remodeling, as I said, is concentric in HFpEF, while eccentric in HFrEF. Very important that we have now started looking at the cardiac MR. In HFpEF, you can have fibrosis which is reactive predominantly in the interstitium. Well, HFrEF has a focal fibrosis, which is basically a replacement type of entity. So the ultrastructural changes are very much needed to be identified and understood. Now, whenever you try to understand heart failure, the concept of cardiac performance comes up, and we always have seen heart as a machine, as a hydraulic pump. Way back earlier when we were looking at the Swan-Ganz, using our Swan-Ganz catheter to determine the cardiac output, stroke volume, the different resistance, and the arterial pressure. We moved on with the discovery of LV cath. Echo started looking at the ejection fraction, the dP by dt curves. The heart is now also looked as a tissue pump, focusing on the usage of biomarkers, looking at the NT-proBNP, the cytokines, and the nitrous oxide. And now it is also looked as a muscular pump, where you start looking at the twist and untwist mechanism, looking at the strain, which can be picked up by echo and also by cardiac MR. So the concept of cardiac performance has evolved over a period of time, and this is coming back to the diastolic component. We were always looking at the guidelines of diastolic dysfunction way back in 2015-16 by Sherif Nagy, but they have now changed it. There are a lot of changes, and these guidelines came almost a month back. Again, Sherif Nagy and his team have given some insights. So the key measurements which are now focusing on the E primes and the EA. So the E prime has come up recently very strongly. The usage of LA volume index has gone down. TR velocity is still there. So these are the all four very important measurements we have to remember. And the first thing which this recommendation focuses is looking at the E prime and the E by E prime, suggesting that if you're looking at the septal level, an E by E prime of 8 is around normal, and elevated filling pressure is more than 15. Lateral E by E prime normal is 10. Anything more than 13 and the lateral side is elevated, and left atrial pressure. And whenever you average an E by E prime of more than 14 is considered to have an elevated filling pressure. So this is one of the important things which has been focused, looking at isolated places of looking at the tissue Doppler in the annulus also. The looking at the EA, the values, when we get the E by A ratio, anything between 0.8 to 2 is considered as a normal diastolic function. And if it is less than 0.8, that is E is less than A, it is called impaired relaxation or grade 1. But if the E by A is more than 2, it is looking at grade 3 or restrictive filling pattern. Now, remember, this is always in the patients who are in sinus rhythm. So these are the important things which have been focused on. The third thing which is looking again is at the left atrial volume index, very important robust marker. You identify by doing by plane by looking at two planes, four chamber and two chamber left atrium, going for a left atrial focused view. And the formula is 0.85 into A1 into A2 divided by the shorter length, and you index it to the body surface area. Anything more than 34 is now is considered as a elevated left atrial volume index. This value is still constant as previous guidelines. New focus, which is always there, but there is a lot of importance has been given to the IVRT, that is isovolumic relaxation time. It is nothing but the time before the onset of E wave and after the ejection phase or the forward phase. So this is the systole which ends and the E starts. This is the IVRT, and the values have been given very clearly. Normally is around 70 to 100 milliseconds, but if it is prolonged, if it is more than 100 milliseconds, it is impaired relaxation, and if it is less than 70 or 60, it indicates a shortened IVRT and high filling pressure. Again, this can be picked up on an echo, understanding that ECG is mandatory in all patients getting an echo interrogation. Now, heart failure with preserved ejection fraction is considered a spectrum where you can have a predominant involvement of the myocardium causing the raised filling pressure, classically seen in infiltrative cardiomyopathy. But you can also have HPpEF because of extracardiac causes, which increases the left ventricular filling pressure or a left atrial pressure. This can be seen in renal failure patients of morbid obesity or liver failure. So heart failure is as a spectrum. As I said, one size doesn't fit all, but the patient can have a lot of problems in this kind of diverse situation. And Sanjeev Shah's group identified also HPpEF into three phenogroups: phenogroup 1, phenogroup 2, and phenogroup 3. The phenogroup 1 are classically seen, are considered as the BNP deficiency syndrome, a better prognosis because there is a very least cardiac remodeling. So if a patient who is coming with HPpEF and you suspect has a heart cardiac problem, but the BNP is normal, you are dealing with this entity. The second is the phenogroup 2, mostly commonly seen where the predominant problem is in the myocardium, have elevated anti-proBNP levels. And the third phenogroup are the worst prognosis, where the patients have associated right ventricular dysfunction, can have renal insufficiency. They are also prone for atrial fibrillations. Now, why this phenotyping is important? Because they have very different prognosis. As you can see, the phenogroup 3 has the worst prognosis. So always, whenever you do assessment on echo, the left atrium and also the right ventricle should be looked at. BNP deficiency or BNP normalcy has a better prognosis, as you can see. So the fifth key measurement is whenever you're looking at the rights at the HPpEF, please don't forget looking at the right ventricle, because looking at the TAPSE and the RVS prime, you can get idea about the RV dysfunction in this. Anything less than 17 TAPSE or anything less than RVS prime of less than 9.5 indicates RV dysfunction. Now, there is some entity which has also come up, is looking at the right ventricle and the pulmonary arterial coupling indexes. So I'm not going to details because this has got a very robust prognosis in these patients. If RV2 pulmonary arterial coupling indices are looked for, they can give a prognosticated information in HPpEF group of patients. Now, there is more to ejection fraction in HPpEF. Looking at the heart failure component, the most important thing is EF. But remember that there have been various cardiac function parameters which can be assessed, like cardiac power output, vascular resistance, cardiac indices. But the recent last 5 to 7 years has given focused on looking at the strain analysis, and all patients of HPpEF should have a left ventricular global longitudinal strain and left atrial strain values assessed, because this gives you understanding about the performance or the subclinical LV involvement in this group of patients. So the sixth key measurement is LVGLS. LVGLS gives you an idea about the health of the subendocardium, and the global longitudinal strain value normally are around -19. Anything towards positive, let's say if it's -12, -10, -9, is giving you an idea that the subendocardium is not healthy. Anything which is more than -19, -20, -21, the subendocardium is good. Now, why this is important, but because you can also phenotype HPpEF beyond the ejection fraction by looking at the strain. So if the HPpEF has reduced longitudinal strain, it involves a predominantly cardiac problem, predominantly problem of the left ventricle, where they can have fibrosis, some cardiomyopathy group of patients. So you're picking these patients at an earlier stage. But you can also have HPpEF with preserved longitudinal strain, predominantly seen in almost around 18 to 23% of patients, where the problem is only isolated in the left atrium. So primary left atrial cardiomyopathy you can have isolated vascular stiffening, you can have isolated RV dysfunction. So these patients can also have HPpEF where the LV is preserved, the LV longitudinal strain is preserved. So this entity has to be identified. The next key measurement, as I said, if you're looking at the strains, is the left atrial strain. And left atrial strain has two components, the peak atrial longitudinal strain, or PLS, or peak atrial contractile strain, or a PACS. The peak atrial longitudinal strain is nothing but the reservoir strain, and all the work has now focused on this PLS. The second important is the PACS, and the normal values of PLS is around 38%, 38. Anything less than 25 in the recent guidelines of shows that the PLS is going down. But anything less than 18 indicates elevated filling pressure. And there is a good correlation between LVGS, GLS, and the LS strains. As I said, the normal values are around 38%, but anything less than 25 is reduced PLS or reservoir strain, and anything less than 18% at a heart rate, normal heart rate, indicates that the patient has elevated filling pressure. So the concept of left atrial strain has emerged because you can have patients having hypertension or diabetes with normal left atrial volume, still the strains going down. Very good important indicator. So there's a couple of works which was focusing on the left atrial strain. One study showed a cutoff of 20%, but the recent guidelines have now given a value of 18%. So the guidelines from American Society of Echo to diagnose diastolic dysfunction and HPpEF gives you a couple of steps. So the first step is to look at the E prime. The first step is E prime, as I said. Start looking if the septal E prime is less than 6, lateral less than 7, or average less than 6.1. Take either of them as 1. Give them 1 level. Go to step 2. You start looking at the values of of elevated filling pressure, you can have an average E by E prime of more than 14, PLS of less than 18, E by A between less than 0.8 or more than 2, or LAVI. So if this is there, it is given 1. If this is there, any of them, you can give 1. So diastolic dysfunction is present if you have number 1 or one of these. But if this is negative, then you need two of these parameters. So the recent guidelines focuses on E primes too much. That is there. So if you have the E prime velocity is going down, then take idea of this, and this is the way you look forward. But they have made a few things slightly more complicated in looking at the filling pressure. So what they say is, this is the step 1. As I said, look at the E prime velocity, look at the E by E prime, and look at the TR velocities. So if all are normal, the patient has the normal left atrial pressure. But if all 3 of them are present, look, you are dealing with a elevated filling pressure, and then you can grade. But if either one is there, if the E prime is reduced, then look at the E by A. But if only TR velocity, then you start looking at the left atrial strain and IVRT, all these things. Now remember, these diastolic guidelines are available online free of cost. You can download it and work for it. But I will try to simplify that this is only valid if the patient is in sinus rhythm, if you are suspecting. But the key measurements which I would like to emphasize now is the tissue velocity, EA, E by E prime, and TR velocity, and also looking at the IVRT and the LAVI. So these are very robust parameter. There is some increment of left atrial strain, where if it is less than 18%, indicates high filling pressure. So you can also do some, if you are doubtful, then there is a role of stress echo, where you can ask the patient to go on a treadmill using a modified Bruce protocol. And if the velocities are not, the E prime velocities are not falling in any of the suggested algorithm, you can ask the patient to stress. After exercise, if the E by E prime goes up more than 14, or the septal E prime velocity becomes less than 7, then the stress test is positive, which is called the diastolic stress test. There is a good amount of information of unraveling diastolic stress test by doing a simple passive leg raising test for around 30 seconds, and it can unmask elevated filling pressure if the E by E prime goes up to more than 14. The advantage is passive leg raising test doesn't increase the heart rate, and so the EA are separated. So this is the role of looking at passive leg raising test on bedside, which can unravel a lot of information. So it's very important that you start doing exercise algorithm in patients suspect of heart failure, because you have to suggest them to go for regular exercise. So this is one of the ways they can condition themselves. And this is some work which we did on looking at exercise and the change in the left atrial strain, showing that if there is a reduction in the PLS, it is associated with 10 seconds decrease in the exercise time what a patient can perform in heart failure HFpEF group of patients. Now, why this is important? Because it has been shown that exercise training does improve diastolic dysfunction, and these are a couple of work which I thought that all patients of HFpEF should have an exercise algorithm at baseline, and they should be trained to go for a regular exercise. So baseline stress hemodynamics is needed in all patients of HFpEF. So let me conclude that start looking at the E prime velocities, start looking at filling pressures. Sometimes 1 or 2 parameters are sufficient. You have to also know the age of the patient, because grade 1 diastolic dysfunction is very common in elderly. I do use medial E velocity very often. Just don't look on echo values only, but start looking at on a patient as a whole. Remember, there are some caveats of E by E prime. E prime is not useful in patients who are having MAC. I didn't touch it because then things can become lengthy. So if you have calcification or if you have regional wall abnormal, and very important, please start using IVRT and left atrial strain to identify diastolic dysfunction and HFpEF, because these are very robust parameters and can be really helpful. Thank you so much. This is diastology in a human fetus of 7 weeks, 8 weeks. Thank you so much.
Thank you very much. It was a real exhaustive and a step-by-step approach to making a diagnosis of diastolic dysfunction. I would just request, we'll just have the next talk before we open this for discussion. It's my pleasant duty to invite Dr. Sirish, who is a cardiologist and an electrophysiologist from CMC Vellore, who has pitched in at the last minute because Muthaiya Vaduganathan had a family emergency and he's not able to join us. I'll hand over to Sirish. Sirish, are you there?
Yes. Good evening, everyone. It's really an honor actually to speak in front of all the doyens of cardiology. I thank Narasimhan sir and Muthaiya to give me this opportunity. My talk today is, sorry, I just start sharing is on the phenotypes of HPpEF and the phenogroups. There's a bit of overlap of this. Can you see my slides, sir?
Yes.
Please go ahead. We are able to see it.
Sorry.
To go to slideshow.
Yeah, yes. Sorry for that. I'll excuse myself just to conserve the bandwidth. I'll just stop my video till my presentation is over and I'll switch it back. Okay. The overview of my talk is basically what our current understanding of HPpEF, its pathophysiology, briefly about primary and secondary HPpEF, mainly about phenotypes and the heterogeneity in the phenotypes of HPpEF and phenomapping and phenogroups. A significant part of this has already been dealt by the previous two speakers. So I'll just brush through where it sort of overlaps with the previous speakers. So historically, we know that HPpEF was called diastolic heart failure, which was a clinical syndrome of heart failure with LVH or diastolic dysfunction. And it was considered that the cardiac problem was the primary problem and the heart failure is a syndrome resulting from that. Our current understanding is changed significantly from that, where we know that HPpEF is a multisystem disorder with involvement of skeletal muscle, lungs, metabolic pathways. And now HPpEF is considered a secondary insult to the myocardium because of the comorbidity related stress on the endothelium and the myocardium. Briefly about secondary HPpEF, the HPpEF by definition with that is syndrome of heart failure with an ejection fraction of more than 50%, and elevated NT-proBNP is seen in many conditions. But some of these disorders have well-defined entity and well-defined treatment, like hypertrophic cardiomyopathy, amyloidosis, valvular heart disease, which are not considered as HPpEF per se. So what I'll be dealing with is the primary HPpEF. Now, coming to the clinical phenotypes of primary HPpEF, the HPpEF, as we know, is a very heterogeneous disorder with a lot of these phenotypes, or some of these are actually risk factors. This is, you can see that this is arranged in a clockwise fashion from at 12 o'clock. It's the most common being arranged at that position. And you can see that the arterial hypertension and coronary artery disease, chronotropic incompetence really amount to about 50 to 60% of these patients with HPpEF. And some of these phenotypes or so-called risk factors are not modifiable, which we know, so I won't go into the details of those. But a significant proportion of these patients have arterial hypertension, coronary artery disease, obesity, and type 2 diabetes. These, even in the primary care setup, these have to be dealt with, and the benefits of treating these go well beyond the HFpEF. So I won't go into these details as well. So what I'll be dealing with today is briefly about the phenotypes or risk factors that are frequently overlooked or not treated frequently. Those are, but still significantly affect the HFpEF population, like in about 30 to 50% of these patients. The first of these is sleep apnea. It's quite common in HFpEF. 20 to 50% of HFpEF patients have sleep apnea. However, treating it has not really shown to have any major benefit on hard endpoints. The RCTs have been predominantly showing that there's improved quality of life, improved BP control, which indirectly may improve the HFpEF, but there are no overall effects of treating sleep apnea on hard endpoints. Now, the second most important and probably the common thing which is seen in patients with HFpEF is atrial fibrillation, which is seen in about 30% of patients. Again, a question previously asked was whether rhythm control is better in these patients. Again, there's no hard evidence to say that rhythm control in these patients has any major benefit. There's one trial which looked at it in HFrEF patients, but that's CASTLE-AF, which has definitely shown benefit on hard endpoints, but that trial has excluded HFpEF. So basically, we still do not have a strong evidence in terms of rhythm control in AF. But of course, we know anecdotal patients where AF is a major component of their syndrome, where rhythm control definitely helps in those patients. Again, chronotropic incompetence is something seen about almost half of the patients, which again, we have indirect evidence to say that that is beneficial to increase the heart rate because of beta blocker withdrawal sometimes improves the exercise capacity. But again, pacing trials in these patients did not show significant benefit in terms of increasing the exercise capacity. So the point I want to convey is there's a lot of heterogeneity in response to the treatment of HFpEF patients. Unlike HFrEF, which is still heterogeneous but has a reasonable response to most therapies that are available for HFrEF. Till recently, it was very frustrating that there was no one drug till the advent of SGLT2 inhibitors or finerenone. There was no one drug that uniformly improved the outcomes in HFpEF patients. So there are several reasons which have been already been discussed by previous speakers. One is it is considered as a multisystem with disease with multiple comorbidities, and the interaction between phenotypes is significant. So, for example, if you're treating AF, it may have an adverse effect on terms of increasing the chronotropic incompetence or vice versa. And same phenotype may have a different pathophysiological effect. So, because of the interactions, the same phenotype may cause the end HFpEF from a different pathophysiological phenomenon. So just treating that phenotype may actually not affect the pathophysiology through which it is responsible for the HFpEF. And also, when variable response, you treat one phenotype and that may actually affect a different phenotype adversely. One thing which I can think of is if you're treating chronotropic incompetence with pacing, that may typical right atrial appendage pacing may increase the LA dysynchrony and can probably adverse that particular phenotype in this group of patients. So basically, till the advent of SGLT2 inhibitors, it was mainly dealing with individual phenotypes, treating one of these phenotypes individually and expecting that the patient will improve. But we know that such approach is not giving us great results in a significant proportion of patients. So there is an impetus to actually try to sort of identify clustering of these phenotypes and unify these patients based on or subgroup these patients based on a pathophysiological mechanisms rather than just phenotypic variants. So if you take this example of this picture, where the blue which excludes secondary HFpEF, and even if you consider the primary HFpEF cases, there's a significant overlap between all of these phenotypes. Now, clinically, it is very difficult because of this overlap in the phenotypes to tease out which of these patients have clustering of these phenotypes and which of these patients have a common pathophysiological mechanism that we can target. So there have been attempts of clinically grouping these patients, so-called CAD, predominant HPpEF, right heart failure. But this again, you're trying to deal with the predominant problem of the patient rather than understanding the overall pathophysiological mechanism in these patients. Similarly, there have been attempts to deal like atrial fibrillation, predominant HPpEF, HCM like HPpEF, and valvular HPpEF. But with the advent of large data models and machine learning, the concept of phenomapping has taken over this clustering analysis. The first attempt at this has been done by Shaw et al. Published in 2015, where they looked at a large database of HPpEF patients from their region and tried to identify patterns based on machine learning to see if there are any emerging patterns from these HPpEF patients. In one of their first papers, first of analysis of this kind, based on clustering analysis, what they found is this large data set, they could tease out three broad groups, phenogroups, which had very less overlap. Of course, overlap was still there, but very little overlap. They brought three groups, phenogroups. And they also showed that these three phenogroups had different baseline characteristics, and also on follow-up, they had different the prognosis in terms of heart failure admissions or, in fact, heart endpoints. Now, there have been multiple attempts again after that, based on proteomics, based on genetic analysis, multiple studies based on old randomized control data. So the emerging picture, at least there is agreement on 4 or 5 phenogroups based on this kind of cluster analysis. There is general agreement that there are at least 3, 4, or 5 groups. One is so-called natriuretic peptide deficiency group. The second group is called cardiometabolic syndrome group. Atrial myopathy group forms a distinct, probably a distinct group, and then there's an advanced or severe HPpEF group. Now, just briefly about these phenogroups which have been emerging in the last couple of years is the natriuretic peptide deficiency group, or in that particular paper, it was called phenogroup 1, were younger patients, mostly females. A common factor binding them was overweight or obesity. And the hallmark of this group was that the patients had low or normal BNP in these patients. And echocardiographically, there were no or minimal changes on the echocardiogram. In the second group, what they identified based on this phenotypic phenogrouping or phenomapping was a cardiometabolic group, where these patients had multiple cardiovascular risk factors, hypertension, diabetes, obesity, and echocardiography or imaging showed significant LV remodeling, both LVH and features of diastolic dysfunction, as discussed by the previous speaker. And one thing was they had a normal pulmonary artery pressure, and right heart was not yet affected. The third group, which probably is emerging and much recently identified apart from the first 3 phenogroups, was the atrial myopathy group, where these patients had fewer cardiovascular risk factors. Mainly it was hypertension. Majority of patients had hypertension. The hallmark of this condition was the LA was remodeled out of proportion to the LV. So LV showed mild changes or mild diastolic dysfunction, but LA function and LA dilatation was a significant part. These patients had high atrial fibrillation, chronotropic incompetence, and secondary mitral regurgitation, so-called atrial functional mitral regurgitation. And the third, again, there's overlap between different authors and different papers, which I have combined them into so-called advanced HPpEF group. The clinical profile is something similar to the cardiometabolic or atriomyopathy group. In addition to that, they had significant renal impairment, pulmonary hypertension, RV failure in various combinations. So it is still hypothetical, but it's interesting hypothesis that probably we are sort of getting to a place where we can think of evolution of HPpEF from one group to other. Again, it's highly hypothetical and speculative. There are no long-term data. The idea proposed by most of these authors is that phenogroup 1, that is the natriuretic peptide deficiency group, probably is an early stage of HPpEF. A proportion of these patients take a different pathophysiological route. A group probably follows a cardiometabolic phenotype, and a proportion follows. A proportion may just remain in that phenogroup 1, but go into a cardiometabolic phenotype or a LA cardiomyopathy phenotype. And probably, if left untreated or if left the risk factors remain untreated, they evolve into a more advanced phenotype where there's a combination of renal dysfunction, pulmonary hypertension, and right ventricular failure. There's an interesting paradigm in terms of future exploration of therapies, because if we can target our therapies to a specific cluster, again, it's hypothetical, we still do not know, but that may give a better result rather than just like trying therapies in a broad HPpEF group as such. So, so what has been proposed is, like in an early NP deficiency, of course, what has been already proven is weight control physical training. But these patients, based on extrapolation of previous trials like TopCat, where it's like patients with actually NT-proBNP, low NT-proBNP benefited the most, subgroup analysis. So whether aldosterone inhibitors are actually more beneficial in this group. SGLT2 inhibitors, again, other inhibitors, and neprilysin, as we know, sort of lyses the BNP. So most of these patients, in fact, had high neprilysin levels. So whether sacubitril can have some targeted benefit in these patients is something that can be explored. Then the second group, cardiometabolic group, we know is it's more typical of the garden variety of HFpEF that we typically see, and already the trials are underway. SGLT2 has already been established in these patients. GLP-1 agonist trials are already underway in this particular group, specifically in HFpEF group. Now, the atrial myopathy group, what has been established is that the control of cardiovascular disease, of course, mainly hypertension. Atrial fibrillation management definitely gives benefit, but it's not very clear whether result control is really superior to rate control. Definitely in anecdotal patients or in clinical experience, patient to patient, the patients who feel much better with rhythm control, but overall whether they benefits rate versus result is still not known. This is something which we can think of where we can target atrial resynchronization, interatrial shunt to decrease the LA pressure, and secondary mitral regurgitation management. These are something which we can think of targeting. Now, the whole idea is to prevent them from going into the more advanced HFpEF group. Now, once they reach HFpEF, again, till date, there is no benefit of pulmonary artery hypertension therapies, but newer therapies like nitric oxide therapies are being explored. Other trials are underway. So hopefully they show some benefit in this particular subset of patients. So to summarize, HFpEF, the current understanding, as we all know, is a multisystem disease with secondary dysfunction of the myocardium. It's not a primary dysfunction of the myocardium, like in most cases of HFrEF. And because of its multiple phenotypes and the heterogeneity, probably it's better to identify a cluster of, group them by clusters and try to identify a common pathophysiological mechanism and try to target them rather than targeting a broad group. Okay, thank you.
Thank you, Sirish. We'll briefly open this for a 2-minute discussion. Really, we are running short of time. In the interest of time, we'll request one of the chairpersons to briefly give a comment so that we can move on to the next talk. Dr. Chandramukhi or Dr. Aziz Khan. Sirish, you can stop sharing. Thank you so much.
Yeah,
thanks. Regarding the therapies in the heart failure with preserved ejection fraction, how long do we need to continue, and whether we can de-escalate the therapies if there is improvement in the echo parameters or the symptomatic status of the patient?
I think, Sirish, you want to take it, or anyone, any of the panelists? Or
The talk is about the therapeutics, no?
Yes, we can probably wait. You're just tailored well into this. We'll request Dr. Abraham Uman to talk about therapeutics, pharmacological therapies in heart failure with preserved ejection fraction. What has...
Larsen, can we ask a quick question?
Yes, please.
To Shantanu, probably still there, I don't know.
No, he's not there.
He is in Dhaka. Yes, he's in Dhaka. He has to go for another meeting, but Dr. Alagason is there as well as Dr.
I'll take the question, no problem.
Yeah, Chandramukhi is also there. Yeah.
Yeah.
Dr. Alagason also is there. One quick question, rather two. The atrial cardiomyopathy group, Sirish also mentioned as a spectrum of HFpEF. Now, I think it is something which is distinct from the LV-dysfunction. In the group that studied this group, Have they looked at the left ventricular end-diastolic pressure or filling pressures and how they changed with the fluid challenge? That is one. And second question is, has anybody studied the echocardiographic parameters with fluid overload? They talked about exercise and leg raising, but is there any data about the fluid challenge like we do in the cath lab?
I am not, again, this is Dr. Siri, sir. I'm not aware, or at least I didn't come across any such study which has looked at specifically challenging to bring out a atrial cardiomyopathy group, but I'm not sure if anybody is aware of such a.
No, no. The usual challenge which we do is either in the cath lab or in the echo lab, do an exercise and look for any evidence of pulmonary LV end-diastolic pressure or pulmonary venous pressure getting increased. That's the thing usually we do. We don't usually use any fluid challenge for demonstrating the LV-EDP rise.
Fluid challenge LVDP is well established, sir. You give 500 ml in 10 minutes, and I have done it myself so many times. It increases the LVDP by 18. The question is, has anybody looked at the echo parameters?
No, I have not read any papers on that, so I have to look up.
That's all, Narsim.
Thank you.
We'll go on.
We'll move on to the next talk, which is very important, eagerly looking for pharmacological therapies in HPpEF. What works and what is in the pipeline. We can't think of a better person than Dr. Abraham Oman, who's been really in the forefront of improving heart failure care in the country, almost setting up a heart failure clinic in every single district. His ambition or goal is to have 1,000 heart failure clinics within the next 2 years. It's up to you, Dr. Abraham Oman. We really laudable goal. We'll like to hear your thoughts on this.
Thank you very much, sir. It's a pleasure being with all the doyens. And my topic is pharmacological therapies in HPpEF, what works and what is new. I've got nothing to disclose in relation to this talk. So this is a real patient. This patient was referred to me by the diabetologist, and she was being treated as COPD and cough variant of asthma for a long, long time. And if you see here, she had diabetic hypertension for a long period. She had an MI, but treated well and had a CABG. The ejection fraction was 65%. BMI was 34. The blood pressure was slightly high, but not too bad in Indian conditions. Blood sugars were quite well controlled. Cholesterol also was, LDL control was suboptimal. GFR was 55, but creatinine was 1.1, but then if you calculate it came to around G55. Urine albumin creatinine ratio is 165. These are things which we generally do not look, but if it is not very costly, and if you look, you will get a very important information. ECG shows atrial fibrillation, and there were echoes before and after. AF was not persistent, and it is paroxysmal AF, but GLS was 14, BNP was 390, and RVSP was 47. The medications were metformin, amlodipine, telmisartan, etc., which obviously is suboptimal. There was no chest pain. Troponin was negative. Dr. Chopra mentioned about H2FPEF score, which I personally like because of its simplicity. And like we always say, keep it simple and safe. That is KISS. And this is very simple way. And we have access to what is called as remote dielectric sensing, which can measure the amount of fluid in the lungs. And it normal is between 25 to 35%. Hers was 40%. So obviously this particular patient, we have heard from the previous talks that patient was HPpEF. The GFR was 55, so it is not totally, it would have almost pre-advanced stage as for the previous talk. We heard this, so she had all the points, but nobody had looked at that prior. So she had all the points here for HPpEF. So what is the prevalence of how common is HPpEF in our country? This Dr. Harikrishnan Toronto Heart Failure Registry was the first and the best registries in the country. And HPpEF 20%, mildly reduced 18%. and HFpEF 5-year mortality was 45%. And so it was not a very benign condition. This is the very preliminary data from the heart failure clinic program. This is from one of the key, very focused heart failure clinic. This is not the common garden type because the numbers are very different, HFpEF. But even in that, if you take overall, the reduced ejection fraction was 52%, and mildly reduced and preserved came up to 48%. It is higher than the trend heart failure registry. But if you look at a very focused heart failure clinic, this was surprising. This is actually last 2 months data. And look at HFpEF. It is 43.4%. REF was low. This was totally to our surprise. And because we are actively looking for it, everybody got a detailed echo, everybody got a BNP or NT-proBNP. The numbers have been almost reversed. That was quite interesting. This is coming to treatment per se. We will see what all of these drugs or medications are important as per our patient. You remember, patient is obese, patient has got albuminuria, and got volume overload, and patient has atrial fibrillation also. Of course, hypertension. And this is the paper that Dr. V.K. Chopra. We are very proud to say that Dr. Chopra was the first author for this international position statement from my Cardio Alliance. And SGLT2 inhibitors here, loop diuretics for controlling the congestion, MRIs in selected patients, ACE inhibitors and ARNI here. And at that time, GLP-1 receptor agonists were kind of little not the major four. And there was some mention about specific treatment for the secondary cause or the like amyloidosis, sarcoidosis, HOCM, Avacamten, etc. But we should never forget, any pharmacological treatment, you should never forget the comorbidities. And hypertension has to be well controlled, sarcopenia has to be addressed, pulmonary disease has to be addressed, associated CAD if it has to be addressed, and atrial fibrillation, especially in HFrEF, sinus node or sinus rhythm therapy, SRT, has got an NNT of less than 10. So, and HFpEF trials are going on, and CKD control. All these things are important because without looking at the comorbidities, and these are the pharmacological therapies are ready for both. There's a HFpEF trials and 2003 to 2024, and from CHARM preserved, I preserve, and you can see here the cardiovascular death, almost everything crossed the line of unity. The confidence intervals were very wide. But heart failure hospitalization, they were pretty good. And I was fortunate to be the site PA for Paragon, Ember preserved, and STEP HFpEF. So the importance is that there was a trend, especially if you see from older to newer, if it's from Emperor preserved to deliver, you can see good benefits and good relative risk reduction. And interestingly, the quality of life was changed as maximum with the GLP-1 receptor agonist. And just mentioning each one by one, the Paragon, which I was part of, narrowly missed superiority by 5 or 6 cases. But when the subgroup analysis showed that females and those with EF less than 57 benefited, subgroup analysis, but still it came in position statements. And this is the combined Paraglide and Paragon combination where patient with recent worsening combined, that showed that sacubitril valsartan rapidly reduced cardiovascular and renal events compared with valsartan alone. And these groups were mentioned, but only thing is our patient had obesity, diabetes, abnormal metabolism, renal injury. So my patient came in the P3 category, and this particular patient in the olden times would have definitely responded to spironolactone. The American paradox of spironolactone in TopCat has already been discussed. Fine arts is an interesting study with finerenone, and you see the key inclusion criteria. If more than 40%, elevated natriuretic peptides, LA enlargement or LVH, diuretics in the past 30 days. The interesting thing is diabetes is not here. It's a non-diabetic population. And the events, significant benefit in cardiovascular death and total heart failure, and p-value of less than 0.007, confidence intervals good, and the predisposed sensitivity for first heart failure event also significantly reduced. Coming to SGLT2 inhibitors, I call it the Vitruvian man. Vitruvian man is Da Vinci's perfect proportions of perfect man. So a person for all seasons. So this is a disease modifier in HPpEF, and this is the only class 1 indication as of now. So summarizing all the HPpEF trials in SGLT2, it reduced total all-cause hospitalization and all-cause death with number needed to treat of 23, which is pretty good. I'm not a great fan of p-values because p-values can, and especially relative risk reduction, because they can hide part of the story. And reduced total all-cause hospitalization NNT of 26. Cardiovascular death hazard ratio of 0.88 and then confidence interval just there. As 1 or 2 would have tilted the balance, but increased event-free survival by 2 to 5 years, 2.5 years. That's important, and increase clinically meaningful health status gains. Multiple mechanism. This slide I love because of simplicity, and I very focused on mitochondrial health. So autophagy, mitochondrial health, and mobilization, renal tubular sodium handling, and attenuation of cardiac hypertrophy may be the reason by which they work. And also it's beneficial in patients with EF more than 60% or normal or supranormal EF. Only the SGLT2 inhibitors have been shown to do so. This is from Harappa, ancient Indian civilization, and you can see that the Indians even at that time had a protuberant belly, and STEP-HF, which is part of, you can see this statistical analysis because it was not event-driven study, and seeing this particular the analysis only, Milton Parker was inspired to do the Summit trial, and it also showed that in HPpEF patients, p-value 0.026, and it continued to widen. That's what I am more interested in because it started relatively early and it continued to widen. And quality of life, there was significant benefit with the GLP-1 receptor agonists compared to others. And this is a very interesting slide because we do not consider GLP-1 receptor agonists as diuretics, but if you look at new loop diuretic initiation or loop diuretic discontinuation, this is SEMA, and there's data with tirzepatide also. It is almost or even better than what we obviously think as with spironolactone or SGLT2. That is something interesting, new thought process. We should never forget the mimickers. It has been mentioned, high output cardiac failure. In our Apollo data, we found that nearly 5% of the acutely decompensated heart failure with preserved ejection fraction, at least of them, had high output cardiac failure. And amyloidosis, sarcoid, hemochromatosis, pericardial disease, hypertrophic cardiomyopathy, all are treated. So look at the mimickers. They may be called as secondary HPpEF, or some people say it's not HPpEF, but you have to look and you can treat. So this is a recent paper, looked at sequencing. And what they said is EF is more than 40%, SGLT2 inhibitors plus non-steroidal MRA. There is CKD add ACR or RNA, diabetic CKD GLP-1 receptor agonist, obesity GLP-1 receptor agonist, EF less than 60 RNA, worsening heart failure RNA. I thought this is a very simplistic and easy to remember approach. Newer drugs, because the emerging therapies, Vicadrostat, selective aldosterone synthase inhibitor, and part of the ECHF trial. Sitavimab is there with Athena and Hermes. Balcinrenone, Dr. G.K. Chopra is the national lead for the Balcinrenone trial. It's a mineralocorticoid receptor modulator. MicroRNA therapies, I am fascinated with microRNAs. I think that is the future, and that can attack the core of the disease. And microRNA therapies are going because last 15 years, there have been about 6 Nobel Prizes on RNA and RNA-related subjects. And microRNA therapies, I believe that it would be the future, and but we have a lot of work to do. Coming back to the heart failure clinic program, the same the most aggressive heart failure clinic, HPpEF. We looked at the data, and the SGLT2 usage was surprisingly low. Nobody had an absolute contraindication. Even then, in that particular hospital, the again ref usage is much higher. So we have long way to go. Beta blocker is no longer recommended as a standard therapy for HPpEF unless there are other indications. So before that, 2 points. One is what happened to that particular patient. That patient was given GLP-1 receptor agonist, finerenone, and was already on ARB, is changed to ARNI, diurest. The patient lost weight, came walking, and patient became class 1 to 2 symptomatic patient. And how long to give? The answer is we do not know. There is no trial like TREAD-HF, but I would continue. There is no magic cutoff, unless there is some side effects, I would continue the medications. So with that, I conclude saying that great science alone will not save life. We need effective implementation, and heart failure clinics is a way forward to it. Thank you very much for patient hearing.
Thank you very much, Abraham. That is a wonderful lecture, and you summarized it very well. I think in the interest of time, we'll have the next question, and then the chairpersons can lead the discussion. May I request my colleague, Dr. Muttaya, to talk about the role of the newer therapies and device therapies in HPpEF. He has been quite active in this area, and we'll have Muttaya present his slides.
Hi, thank you, sir. So I hope you can see my slides and hear me. So we'll be next talking. I think we've heard a lot about the diagnosis and now the pharmacological management. This is just another sort of opportunity to look at patients a little differently, understand the actual pathophysiology in HPpEF and how pacing may actually help these patients. So this patient, she's a 48-year-old female, non-obstructive HCM. But the basic pathophysiology is diastolic heart failure. And like most of these patients, when they're dependent on their atrial cric, when they develop an atrial fibrillation or atrial arrhythmia, they become quite sick. In sinus rhythm, they are better. What's more interesting here is if you can see this baseline ECG after cardioversion, this P wave is a little bit broad. And this is where the beginning of the understanding of an interatrial block, that is a conduction delay between the RA and the LA occurs. So in this patient with a baseline interatrial block, we went ahead and implanted a dual chamber ICD. This was required for prevention of sudden cardiac death. But at that point, our understanding of how to pace, what we were pacing, what we were looking for was less. But we wanted to at least cosmetically improve the P wave duration. And that's what we did by pacing in the high right atrial septum. We were able to narrow this P wave into a very narrow P wave. So cosmetically, the ECG was better. But what was more important is you can see the difference here without pacing, that is in sinus rhythm. You can see the E by A relationship, and we've just heard multiple talks. So this is something that we would call grade 2, grade 3 diastolic dysfunction with a high E and a small a. Now, when pacing was turned on and we paced at this Bachman bundle or high right atrial septum, you can see the gross difference in the EA relationship. So what has changed is not the A, but the A has become bigger and broader. So this showed us that by pacing in this area, you're not only improving the ECG and narrowing the P wave, but there is some hemodynamic benefits as well. So just trying to understand what is the relationship when we talk about someone with HPpEF is, I think it's not a very easy pathophysiology. So on one point, we have seen, and multiple people have mentioned, the atrial myopathy component. So there is actual atrial disease that is beyond the sort of conduction system. And the second part is the electrical dyssynchrony that is caused by the conduction disease between the RA and the LA. And then to sort of complicate, have the chronotropic incompetence where the relationship is different at rest and very different during exercise. So when we're trying to put all of these together, we're trying to understand whether a pacing modality can sort of combine and treat all three of these pathophysiological mechanisms. So I won't spend too much time on this slide, but this is basically the way that we look at the ECG diagnosis of interatrial block or delay. So we're talking about a delayed activation between the right atrium and the left atrium, and we diagnosed this based on the P wave duration in the lead 2-3 AVF, and based on the morphology and the duration of usually more than 120 milliseconds, we can say either it's a partial or a complete interatrial block. But I won't get too much into this so that we can understand a different view. The most important part is not everyone with HPpEF has an interatrial block. Not everyone with an interatrial block has symptomatic heart failure. So we are looking at a subset of patients where these patients are dependent on their atrial kick or atrial booster function. These are usually patients with HPpEF phenotypes or diastolic heart failure. And what you see here is, this is a study done almost 15 years ago, where they saw in sinus rhythm 7 patients with HPpEF, where there was an atrial dyssynchrony between the E. What is the dyssynchrony? The A is small, it's truncated. You're actively not creating any atrial kick or atrial booster for these patients, and hence they are not doing well. They pace the distal coronary sinus. So in essence, they are pacing the left atrium, and they are trying to sort of reverse or resynchronize the RA-LA dyssynchrony. By pacing, they improve the P wave, but they also improve the E by A ratio and the atrial hemodynamics. So this was the first study that showed that by pacing, you can improve not only the P wave, but you can actually, in essence, improve the left atrial mechanics and the left and the LV filling pressures as well. So then the goal looked at different pacing modalities to sort of understand how best to pace. And the concept of the Bachman bundle has almost, people have been trying to pace at this area for the last 20-25 years. Now, what I won't spend too much time, but what we need to understand is the Bachman bundle per se is an epicardial structure. What we are trying to do is trying to pace in the right endocardium some of the few fragments of the fibers that are coming and sort of fanning out to the right atrium as well as to the left atrium. The easiest way to pace these fibers is to pace from the right endocardial aspect. And that is what I will show. So oftentimes for the last 20 years, this has been on, off, on, off. And the reason was maybe a lack of understanding of where to pace and the tools in which to reliably pace this area with good results. Now, I think Dr. Oman already alluded to this, but there's a sort of a paradigm shift in the way we have looked at heart rate management in patients with HPpEF. In the past, it was always recommended you give beta blockers or non-dihydropyridine calcium channel blockers to improve LV diastolic filling in HPpEF. The original studies were very observational, but the idea was that if you prolong the diastolic relaxation period, you would improve these patients in terms of their treatments. But what we have slowly seen is that these sort of heart rate suppression trials in HPpEF, be it with beta blockers or rivaroxaban, have shown neutral and sometimes negative results as well. So these guidelines have stopped recommending any sort of heart rate reduction in the HPpEF population. And I think one of the most important pivotal trials that I'll show you is the MyPace trial, which actually showed that higher heart rates are beneficial in the HPpEF population. So just to understand this pathophysiology, so what do we understand? This is an LV end diastolic pressure volume loop, but the hallmark of the pathophysiology is an exponential increase in the end diastolic pressure relationship in these patients with HPpEF compared to a normal healthy patient. So there's a slight difference, and this is where the component of the heart rate also has to be taken into account. So at a lower heart rate, you prolong diastole, and yes, there is a slightly increased LV end diastolic volume, but this is counteracted by an exponential increase in the LV end diastolic pressure, and that is why patients don't do well at a lower heart rate. At moderately higher heart rates, and there is a sweet spot for this, the curve moves down and to the left. So this, because of the higher calcium mechanisms and calcium modulation, there is actually a reduction in the LV end diastolic pressure, but compared to the effect on the end diastolic volume, there is a significant reduction in the LV end diastolic pressure. And this is why patients do better at a moderately higher heart rate. Again, when you go to even higher heart rates, and I'll show you what I mean, this relationship doesn't hold true. So this is the whole mechanism of the MyPace trial, where they try to increase the resting heart rate. They took patients with stage B and stage C HPpEF. These were already patients who had a device, and they programmed these patients with roughly around 10 to 12 beats per minute higher heart rate than their basal sinus rhythm. So in essence, you are increasing the basal resting heart rate and pacing these patients from the right atrium. This was the first study that looked at the moderately accelerated atrial pacing in patients with HPpEF, and they showed not only an improvement in NT-proBNP, but a big difference in the physical activity, quality of life, and the AF burden. So the takeaways from the MyPace trial was that definitely a higher atrial rate is better for the HPpEF patients. But the other two sort of things was they even were able to show slightly improvements in the LA remodeling in some of these patients on long-term follow-up. The second important study, and this is the second one, is that so now that you know that at rest, a slightly better heart rate is better. So does this hold the same true for exercise? And we've seen many patients with HPpEF in the OPD where even a small amount of exertion makes these patients very symptomatic. And to understand whether the same result holds true during exercise, this was the RAPID HF trial, which looked at rate adaptive pacing. So basically, you're increasing the heart rates during exercise. But this was a negative study, and despite pacing these patients around 100 beats per minute with rate adaptive pacing, there was no improvement in the BNP or quality of life. And so then we can understand that HPpEF is a very complex pathophysiology. What works in terms of resting heart rate modulation doesn't hold true at higher exercise. And the reason here is that because when your heart rate goes up, yes, you do reduce your LV end diastolic pressure, but when the heart rate goes up too much, you actually lose the stroke volume and hence lose the extra benefit that you get with the reduction in the LV end diastolic pressure. So if we try to put this together, you need to understand that definitely a moderately accelerated atrial rate is beneficial. Now we're trying to combine that with a more physiological atrial pacing mechanism or through this Bachman bundle pacing. And if we offer physiological atrial pacing at a moderately accelerated rate, is this the sweet spot for treating HPpEF patients? I won't spend too much time on this, but this is our approach to Bachman bundle pacing or atrial conduction system pacing. And our results have improved basically because we have started looking at the electrograms and also looking at doing sheath-supported conduction system pacing tools to identify the target site for Bachman bundle pacing. And we try to map these Bachman bundle electrograms at the SVCRA junction. We prove these patients have reliable conduction system capture, and we have proposed a criteria for adequate Bachman bundle capture based on recording of the potential P wave morphology on pacing, as well as the short P wave. So this was our initial experience with roughly 35 patients, where this method was successful in roughly around 88 patients overall. But that's not this. I think we'll just spend a couple minutes on this study. This was our recent study where we looked at a very specific subset of the HPpEF population. There's always a debate whether non-obstructive HCM should be labeled HPpEF or not, but the phenotype works the same. So they are non-obstructive HCM, symptomatic patients, and these patients all had interatrial block on the ECG. So these patients had indication for primary prevention ICD, and the study method was that if we were able to achieve Bachman bundle pacing, these symptomatic patients would undergo randomization to either Bachman bundle pacing on at 70 beats per minute, that is moderately accelerated atrial rate, or Bachman bundle pacing off at 70, which was LRL 30 beats per minute. This was done only for 4 weeks. Washout was done, and then they were crossover to the other arm. The control arm, just to make sure that it is not only the site that is being affected and the rate also matters, is a right atrial appendage historical cohort arm, similar patients where the bleed was already in the right atrial appendage, where these patients were paced for at 70 beats per minute for 12 weeks. The study endpoints were, we wanted the primary endpoint to be a change in NT-proBNP, but functional, diastolic endpoints and atrial arrhythmia burden were all included as secondary endpoints. Our baseline characteristics were similar to our previous studies with non-obstructive HCM, but the important thing to look at is we were able to narrow the P wave successfully or Bachman bundle pacing in roughly 90% of the patients, where the P wave became from 151 to 115 milliseconds. And I'll show you the primary and secondary endpoints. So this is probably the most important slide. These are two patients. One is with a non-obstructive HCM, complete interatrial block, baseline and right atrial appendage pacing. So what happens when you pace from the appendage? We need to understand that anytime you pace from the appendage, you are actually increasing the atrial dysynchrony. You are actually making the P wave broader, and you may be inducing further dysynchrony between the RA and the LA. And that is what happens. When you pace from the appendage, the P wave duration prolongs. But also you see that there is not much of a change in the diastolic filling pattern. When you pace from the Bachman bundle, a similar patient, you narrow the P wave. So cosmetically, you have electrically resynchronized. But hemodynamically, you see a big change in the EA relationship, especially with the A wave becoming broader and longer. So this is probably one of the reasons why the primary endpoint of NT-proBNP was significantly less in the patients where Bachman bundle pacing on was set during the crossover period. All the diastolic parameters, E by A, E by E prime came down. 6-minute walk distance, NYHA class improved. And I think one of the big things was the daily diuretic requirement almost came down by 40 milligrams of furosemide equivalents. So we are now expanding this to look at a broader HFpEF subset. The idea is same, to include symptomatic patients with HFpEF based on symptom class and BNP. Excluding patients who we feel that this is beyond them, or persistent AF or severe valvular disease. And the question always remains, is it the site or the rate? So we are randomizing these patients. Both pacing arms will be at 70 beats per minute, so at a moderately accelerated rate. One arm will be Bachman bundle pacing, one arm will be right atrial appendage pacing. And we feel this is the best method to answer this question. So we have just started recently recruiting patients for this study. We're doing it both at AIG and CMC. And this is a fully studied by a study grant. So these patients that are enrolled, the device, the implantation follow-up is all free of charge to the patients. So I think that this is my last slide. What do we know about atrial resynchronization therapy is that we know correction of interatrial block is helpful. It does have hemodynamic benefits, especially in the HFpEF subset. We need to look at longer outcomes. We need larger randomized studies. And we also need to understand that there may be smaller potential subset within this large heterogeneous HFpEF population that may really benefit from this therapy. So I'll stop here and maybe we can have some discussion. Thank you.
Thank you, Muttaya. I'll hand over this session to Dr. Dayasagar Rao, Dr. Shastri, and the chairpersons, Dr. Shanmusundaram and the others. Are there any questions and comments?
Yeah, Narsivan, to just kickstart the discussion, Muttaya, just wanted to just make a comment. You said non-obstructive hypertrophic cardiomyopathy as a surrogate or in place of HFpEF. I think that may not be appropriate, because HFpEF is basically a systemic vascular disease, a metabolic disease with a lot of implications. And non-obstructive hypertrophic cardiomyopathy is about the purely diastolic dysfunction of the heart. Heart failure with preserved ejection fraction is much more than the diastolic dysfunction. That is one point. And second thing, just a suggestion, I realize there is no data, at least I'm not aware, of the propagation map and voltage map of atria in patients with HFpEF. That is a very low-hanging fruit. It may give you some insights.
And thank you so much, sir. So I completely agree, sir. It's not completely fair to say non-obstructive HCM as a HFpEF population. It's just that maybe the pathophysiology has some similarities, but I agree with you. And yes, definitely looking at the atrial activation, biatrial activation in these patients will have some insights as well, sir. Thank you.
Look at the voltage map also.
Yes, the voltage map is.
But HCM also has microvascular dysfunction. There are people with microvascular dysfunction. There are people with ischemia. There is fibrosis, which happens in patients with hypertrophic cardiomyopathy, which can lead to the heart failure with preserved ejection fraction type of phenotype in that. So it is also associated with microvascular dysfunction, ischemia, even the muscles compressing the coronary artery, producing the ischemia, all those things. So it is somewhat similar to the other phenotypes. That's what I thought.
You know what Dr. Shastri means? HPpEF is more a systemic disease rather than disease confined to the heart. I also agree with Dr. Shastri. I think HCM should be viewed separately than this the HFpEF population.
This is Dr. Dasagar. I have one question to Dr. Muthaya.
Yes,
Am
sir.
I audible?
Yes, sir. I can hear you, sir. Please.
This change in the flow pattern, has it really resulted in any improvement in the exercise capacity?
So yes, sir. So in this study, we looked at the 6-minute walk distance as a surrogate for the exercise capacity. So when pacing was on, almost 100 meters in terms of the 6-minute walk distance was improved. And we need to remember this was just with 4 weeks of pacing.
100 meters is a huge difference.
Yes, yes, yes.
I think part of the thing is the reason why we took this up was we realized HFpEF is a very heterogeneous mixed bag. So we wanted to kind of take a pure subset where there is a significant atrial dyssynchrony, and that is marked by a marked prolongation of the P wave. And it's predominantly for the very same reason that Dr. Shastri said, we didn't want a predominantly inflammatory phenotype. So to look at this mechanism, we wanted to first test it in this. And I fully agree there are probably subsets of patients where this is not going to work. Probably the ones with impaired GLS of the ventricle, and it may not work very well, but this is what it is.
So I think it is high time we differentiate atrial cardiomyopathy from the left ventricular diastolic dysfunction. So the epicardial fat, atrial epicardial fat or some other mechanism may be more important in the atrial cardiomyopathy, and it may exist without LV diastolic dysfunction. That's why I was earlier asking, in the subgroups of atrial cardiomyopathy that were described, what are the LV diastolic function parameters? Atrial cardiomyopathy may occur secondary to LV diastolic dysfunction, but may also occur independent of that.
Muthaya, is there any way of detecting mechanical dysynchrony between the atrium? Maybe like, echo, any other method? You're unmute. You have to unmute yourself.
Muthaya, you have to unmute. Basically, you can show the slide between tricuspid A wave and mitral A wave. So from the beginning of the P wave. You do have the slide, nothing.
Yeah. So no, I mean, it's just the same way that we measure interventricular dysynchrony. You use the mitral and tricuspid Dopplers and look at the beginning of the P to the beginning of the A wave on the Doppler set. And usually it's supposed to be less than 70 to 80 milliseconds. If it's more, then you have an echo way to say that there is.
Which starts first, usually?
Tricuspid. So the right side starts first, sir. So right side starts first, and within 70 milliseconds, you're supposed to have the A wave on the left side.
Dr. Oman, how do you manage people with atrial fibrillation? What drug you use? Acute setting and long-term care?
Yeah, that is $1 million. There are a lot of electrophysiologists here, but HFrEF is very simple. I try to push them for the ablation because I believe that sinus rhythm therapy in HFrEF is, we have got real data. HFpEF, we do not have that kind of data. So I would rather depends on the patient and the symptomatology or the AF symptoms rather than the heart failure symptoms. So this is one situation where I might give beta blockers. I'm not a fan of amiodarone, so because I don't like comparing amiodarone with anticoagulation. This anticoagulation is absolutely important. So that would be my approach. I would give beta blockers. I try to keep the rates down. But digoxin, initially there was some few data, but then subsequently there is no data on HFpEF. So that is a kind of evidence-free zone from therapy point of view. But I would get an opinion from the electrophysiology colleagues also. If they're symptomatic based on like the atrial fibrillation, yes, acute, I may try to cardiovert. That would be my approach. So there is Dr. Narasimhan, Dr. Muthaiah. How do you approach AF in HPpEF? Because I think the Cabana HPpEF is going on. Cabana, one of those. Athena, one of those. So
the thing is, this is echocardiography makes a lot of difference. When you have intraatrial delay in HPpEF, that's a different subset of patients. Very often we find there is an intraatrial delay and then they develop atrial fibrillation. So in them, especially if they have a normal PR or a right bundle branch block, the left ventricle starts contracting first because the right bundle branch block, the LV is reactivated first and the LA will be contracting against relatively a closed mitral valve. So there are finer areas where, in fact, when we do the study, we find the left atrium is almost contracting on the QRS or even much later. So these are subsets of patients where we find we have a lower threshold for pacing rather than ablation. Whereas if you have the P wave that is normal and there are spurts of atrial fibrillation occurring, then they respond reasonably well to drugs like. If they don't have coronary disease, we use a low dose of flecainide to slow this down.
So this meeting is for the only 12 of us, or
No, there are questions in the chat box which are coming up.
One second.
Muthaiah, can you?
I'll get it, sir. One second.
In fact, the congestion is a dominant figure. How often do you have disproportionate pulmonary hypertension in these patients, Shastri?
Yeah, very often. Very often. It becomes difficult to treat because as the disease progresses, they tend to have combined pre and post capillary pulmonary hypertension. And there's no way of certain way of treating it. Yeah, predominantly we give diuretics. If we give pulmonary vasodilators, the sildenafil probably or the PDE5 inhibitors may have some role. But again, the data is very variable. If you give endothelin receptor antagonists, they don't do well.
Okay.
But if the pH is disproportionate and if you do a cardiac catheterization and there is a diastolic pressure gradient is very high or the transpulmonary gradient is very high, very cautiously one may start endothelin receptor antagonists, but it will be difficult. Now there is, I think, recently some paper saying that probably sotatercept, which has got reverse remodeling in the pulmonary vasculature, may be helpful.
Shastri, do you think that drugs like vericiguat, riociguat will be of some use in this population?
Possible, I don't know. Riociguat is helpful in pulmonary hypertension, especially the nitric oxide synthase pathway is impaired in these patients. So maybe cautiously we can give, but you have to make sure that riociguat is not combined with the nitrates or sildenafil.
There's a question from the chat box about when do you use finrenone in this subgroup of patients? Probably Abraham Woman can take this.
yeah, finrenone actually the fine arts a good trial. So that is why I showed that chart. The easiest, lowest hanging fruit is diabetic patients with some amount of proteinuria and HPpEF that you can go and there is significant benefit. And non-diabetic, that is Figaro and Fidelio. And fine arts with non-diabetics also there is benefit. So, but it is slowly coming into the guidelines. But fortunately, most of our patients are diabetic or pre-diabetic. So that makes it easy. So my approach would be decongest, SGLT2, non-steroidal MRA, quite high in the list, then only followed by ARNI. I may prefer ARNI because I was due to many reasons, non-scientific reason is that I was part of Paragon and very narrowly missed superiority. If there were 6 or 7 more patients in the events in the placebo group, it would have been talking differently. So that is an almost trial. So I would give RD. That would be my approach. So affordability is an issue, but I will check the potassium. If it is affordable, I would even individualize, and even non-diabetics, I would give Finerenone early.
Abraham, can I ask you? I mean, Nasivan, can I?
Yeah, please.
Abraham, can I ask you 2 questions?
Sure.
Why is the Finerenone studied against eplerenone or spironolactone? And if not, why not?
There is an old study, 2005 study, George Backer said. It is not an event-driven study, but I forget the name of the study, but it was headed by late Dr. George Backers, and it showed superiority. So but not an event-driven study, that also I have to say.
Superiority in terms of?
The renal endpoint and NT-proBNP, if I remember correct. So I can share that details with you. So there's an old study, that is a small study, but there is data. So it is not that there is you should have compared with spironolactone. And the SPIRIT trial, there are 2 trials who are ongoing with spironolactone. To the best of my knowledge, one has been discontinued. Reasons unknown. There's one more study with spironolactone ongoing. Like it may come back, and then I would give spironolactone, especially like if the EF is less than 55 or so, and especially if the GLS is on the lower side, I would, and affordability is an issue, I would give spironolactone. So spironolactone is not a no-no for my practice, but question was specifically Finerenone. And if the point was that if the patient can afford a relatively smooth drug with lesser side effects, so that is how, and more data.
I have a suspicion spironolactone is much more harmful in HPpEF than FREF. The whole physiology of hypertension, hypertrophy, fibrosis, everything is mediated by spironolactone. I mean, aldosterone.
I have one question, Dr. Abraham.
Sir.
Can we give Finerenone to these patients in the absence of proteinuria?
Absence of, sir?
Proteinuria.
Actually, fine art study was precisely that, because fine art study, like, so it's basically HPpEF, pure HPpEF trial mostly. So the answer is based on fine arts, yes. Has it come to guidelines? Not yet. But the coming guidelines may give at least class 2A indication, because there is data, combined data in fine heart also. And interestingly, when fine heart, they combined fine arts, which is a HPpEF trial, Fidelio and Figaro, and huge number of patients. And they found reduction all-cause mortality. It's not very often that you see all-cause mortality reduction in the current day trials. Even SGLT2 inhibitors did not show. I saw this slide. The mortality was not exactly reduced. So it was all-cause mortality, not cardiovascular mortality. Cardiovascular mortality was reduced, but not statistically significant. So I would believe that it would be a class 2B or a class 2A indication, because valsartan sacubitril got a class 2A indication straight away with basically one study. So I would believe it would get a class 2A indication in the coming guidelines, even in the absence of diabetes or proteinuria.
No, there are a couple of questions in chat box, but in the interest of time, I would like comments from all the panelists and the chairpersons and the panelists. We'll probably post the questions directly to the rest of the people. I would like any of the panelists or chairpersons, if they have important comments or questions, we'll first address them.
Not a question, Nasivan, but a comment. Very often we see patients receiving alpha blockers for hypertension management in patients with HPpEF. Alpha blockers increase the fluid load, congestion. So for various reasons, they think that they can't give AS inhibitors, ARB, or calcium channel blockers. They end up giving alpha blockers. That is one practice I think they should give up. And in spite of many talks like this, people correlate heart failure with ejection fraction. That has to be read. Heart failure is a syndrome, constellation of signs, symptoms. We forgot the basic, our own rheumatic heart diseases, mitral stenosis, presents with heart failure, but still we don't classify. So heart failure is, heart failure is heart failure.
A lot of them are seen by as asthma, adult onset asthma, wheezing, so on and so forth. I think that's altogether, your point is well taken. We need to kind of, because most often when a physician sees a normal EF, he more or less excludes cardiovascular disease. That's a cognitive bias, and we need to kind of address this. Your point is well taken. And I think in the interest of time, I'm glad that we had, it's more to kind of educate ourselves on this arena. And there are a lot of people who are logged in their YouTube. We'll address the questions separately. In the interest of time, I would like to close this session by thanking each and every one of the panelists, the speakers, as well as the chairpersons. And if there are any questions, we'll come back to you and post directly onto the chat box. Thank you all very much and good night. Thank you.
Good night.
Good night. Good meeting, Narsim.
Thank you.
Thank you, sir.